Hello and welcome to the Auditing Antics podcast. So happy to be back, happy to be feeling better. Today I have my new headset, so we don't have the issue of the broken pieces, and my audio should work a lot better this week, so I'm happy for that. Now, before we jump in, Michelle, I just want to cover quick. Terry Fletcher and I have been pushing a lot of content or, updates out there about a telehealth event that we're going to be having next week. Still hearing from people that they didn't see the update. So I want to make sure I put this out there as much as possible. So if your organization currently does telehealth, or if you started it, for example, during the pandemic, you've got to make sure that everything is compliant. And, up to this point, in my personal experience with my clients, when I audit for the first time, there's typically issues, whether it's with documentation or coding. So next Thursday, September 18th, yes, Thursday, September 18th at 10 a.m. Eastern, Terry Fletcher and I are going to be hosting a live webinar event. And what we're going to be doing is breaking down where everything is at now, what has a potential to expire. So at the end of September, the 30th, there's potential flexibilities and waivers that are going to be going away. And then at the end of 2025, we have the same thing. So we're going to look at what that uncertainty is right now. Obviously, things can change day to day. So we're going to have the most up-to-date information at that point. We're going to make it very clear what is the unknown, and then we'll break down what everyone should be doing currently and in the future to make sure you remain compliant. So you can go to my website at stephanieallardconsulting.com. I have a link that goes to the Eventbrite event. And if you use the code TLH10 at checkout, that'll give you 10% off the event. One last thing, this is approved for CEUs. So on the image here, you'll see for AAPC, AHIMA, QPro, PMI, BMSC, it's approved for 1.5 CEUs. So that's always a plus as well.
For
All
sure.
right. So Michelle, we're going to be getting into a Q&A episode, and I always
Yes.
like these because I get asked a lot of questions. Sometimes people are messaging me privately. Also through my membership, it's coding compliance connection, lots of C's. That's the large benefit that a lot of my members use as well, as submitting their questions. And as a part of that membership, just a quick plug here, the questions are unlimited and I do respond within 24 business hours. So if you need any of that kind of personal support for you individually, your organization, I actually have multiple billing companies as well that partner with me in the membership to help with their compliance and staying on track. So this is just kind of a sneak peek into what that can look like if you need that support. And, it's always fun to dive into the common questions that we get on a regular basis.
Okay, so are you ready for question one? I
Yes.
have to laugh because I
Michelle's
kind of
the
feel
host
like,
today.
when you were in elementary school and your teacher decided that everybody was going to go around and read one paragraph, I'm like, and you're like trying to count the number of people
Yes.
before you. Well, I have not had the opportunity to read my paragraphs. I mean, I'm convinced that's where anxiety started. In history class, asking you to read your paragraph. But okay, question one. Is it okay to bill a physical therapist under a physician in the same group while we are waiting for credentialing to go through?
Okay, so the answer is no, but let's break that down. I
Hmm.
get this question quite a bit about just providers in general, right? You have new staff that are starting, they're not
Hmm.
credentialed yet, you've got to wait a while, and what are you going to do? You're going to be out revenue. Not everybody really has that figured out either with their onboarding to make sure that they're
Yeah.
doing that from the beginning. So the reason that this is problematic, and recently I have been asked more specifically about this as it pertains to a physical therapist. And the reason this is an issue is because they're trying to fit it into the bucket typically of incident two. But when we look at incident two, remember that other practitioner that is working incident to the physician is not the one who can make the decisions. And I don't know about you, Michelle, but when I work with physicians that are in practices with physical therapists, I always come across the scenario and really that brick wall where that
Mhm.
relationship doesn't work because the physician doesn't have the medical training to come up with the physical therapy treatment plan. So
Yeah.
when I discuss this with clients, that right there negates the entire conversation because that physical therapist cannot act autonomously. They have to listen and follow the written plan of the physician in order to qualify for everything when we start digging into incident two. So it's not just a matter of the relationship or who does what as far as specialty and things like that.
Mhm.
When we dig into the rules, it just doesn't work out with that as the main reason.
Yeah, and I think that sometimes the reason why there is some confusion associated with this billing, under the physician is because they do have to have that sign off and certification on the plan of care. However, it was not created by the physician or the NPP. It's still created and developed by the physical therapist, and they're the ones who are going to carry out that plan or
Mhm.
supervise a PTA, for example, to carry out that plan. So I do think that does introduce some level of confusion that this would be allowed because they're certifying the plan of care. But we
Mhm.
still have to look at who did the work of
Yes.
developing that plan of care. And that, when it comes down to it, is the physical therapist. I don't think I have ever seen where an MD or an MPP has actually developed that plan of care.
Yeah. Yep. Exactly. It just doesn't fit with the clinical workflow.
Yeah, no, it doesn't. So our second question, can a certified CPC coder change the CPT and ICD-10 codes?
Great question. So I get asked this a lot because sometimes within practices there's uncertainty or there may be pressure from physicians, the APP practitioners, things like that. So when we think of it at a base level of what our role is as a coder, an everyday production coder, we are reading documentation and validating what CPT codes and ICD-10 codes and sometimes HCPCS codes are supported based on supporting documentation. So the answer to this is yes, a coder can go in and update those codes, but you want to pause to think about the role that you play in that practice. What I mean by that is some people may have training, some people may even be CPC certified, but they're working in the role of a billing associate at the time. That would not be appropriate if your primary function as a staff member is not medical coding and then billing attached to the medical coding piece. Now, the reason that at times our providers are not comfortable with this, and we need to understand that when that claim goes out the door and it has that physician or APP practitioner's NPI on that, that is attesting to the fact that they rendered those specific services and they have documentation supporting that. So sometimes where this conversation comes from is a lack of trust, or maybe it's a new relationship even between a coding department and a provider. And you have to understand that your physicians and APPs have risk at stake. So they need to be
Mhm.
comfortable as well. A lot of times, this will also lead to the discussion about workflows and whether or not a provider wants to see the codes that are being changed and sign off on it before you're allowed to do it. So, yes, it is compliant to change it because we're changing it based on what's in the note. But you've got to think about that other aspect and then set up your workflow for the practice that way.
Yeah, that definitely is a good question because I know I have had providers come to me and say, who are you to change my
Mhm.
coding? And we've had to kind of roll that conversation back and
Yeah.
give a little bit of an explanation. And like you said, sometimes there has to be a relationship built there
Mhm.
and working together. But that was a great question. So, on to our next one. How do you handle the scenario when the clinical workflow is set up like split shared, but the providers are seeing the patients in the office setting and the physician wants to bill for the services? The physician is seeing the patient along with the NPP, and the NPP is authoring the majority of the note with the physician just agreeing and signing.
Okay, so the first thing I want to clarify here is that our directions are going to be different depending on, I'll call it private practice and then a facility based clinic, right?
Hmm.
Because in private practice, our freestanding offices, our place of service is 11.
Hmm.
Now, if you're in a facility, what we're about to talk about is not going to be applicable if your practice is located in that hospital campus, because that is going to be place of service 22 for an outpatient clinic. So we want to make sure we understand that first. So
Hmm.
the when we're talking about this place of service 11, the outpatient freestanding clinic, what ends up happening here is that clinical workflow does not match with compliance and what we must follow for billing purposes, right? Coding
Yeah.
and billing. So this situation, first of all, you cannot bill incident two because there's no such thing as split shared in that setting. And incident two is not met when they're sharing this patient together, and that physician is not independently seeing the patient initially, creating the work plan that then the NPP is going to be following. And for me, this leads into a lot of other conversations, and I have different practitioners who get upset with me, or physicians, I should say, who get upset with me when we talk about this. And the first thing they'll say to me is, well, my PA or my NP is a scribe then. I'm going to just call them a scribe then. And it's like, okay, but we know the clinical workflow is not
Yeah.
compliant with what's being done. We're not going to let that pass. So,
No.
in addition to that too, Michelle, I don't know if you've had this scenario, but when NPs or PAs, or even I've had RNs yell at me in meetings before because they're angry when we talk about a scribe. And they're like, I'm not a scribe. And it's like, yes, I understand that, but they're saying you're performing that function, which at the end of the day, that'd be a pretty highly paid scribe.
I'd say.
Yeah,
I I mean, I could think of a lot more cost effective a way to get your note documented for you than
yes.
using an an APP or even an RN.
Yeah. And we have to remember too, so legally they have their own licensing
Hmm.
and they're credentialed with payers. They are a billable provider on their own standalone. So if you have to hover there with them and you can't trust the work that's being done, then okay, let's question that on the clinical side, on the operation
Yeah.
side of things. I will say I've met with not many, but some physicians, for example, who are pretty derogatory towards those that they work with,
Oh,
more
yes.
in a multi-specialty group when they're not the ones specifically hiring and all of that. And,
Yeah.
you know, they can get pretty nasty sometimes and say, well, I don't trust them. I would never let them make a decision, blah, blah, blah. But it still doesn't change the fact that that workflow doesn't work and you can't set it up that way, and that physician cannot continue to bill that way.
Yeah, I think what I see most commonly in these scenarios is the entire note has been documented by the NPP. And then you see this sentence in there: the patient has been evaluated by Dr. So and so. And then they think that covers them because they're like, oh, the doctor was in the room. So this certainly is the plan of care. But when you
Mhm.
read the note, it's by the NPP. So it gives the perception that the MPP is the one who has developed this treatment plan. So even
Right.
just saying that they saw the patient isn't enough to support that incident too. You have to have that independent evaluation and development of the treatment plan.
On their own.
Yes, on
No
their
help.
own. So, on to our next question. Why is it not compliant to bill a level 3 in a residency program when the faculty physician was unavailable to physically precept? The documentation supports moderate MDM as the patient had multiple chronic conditions requiring refill of multiple different drugs. So they're asking, why can't we just downcode it under that primary care exception rule?
hmm So this is a big issue, and what I've noticed in the work with my teaching facilities is that this was always an issue prior to the pandemic, but then it got worse during the PHE because CMS had some flexibilities on what they considered that physical precept. So what is happening is, yes, a lot of organizations, I've even worked in some where if you see that it's, a non-physical precept, for as a coder, we were directed just down code to a 3 because we still want to get paid. But the
Hmm.
problem is when you dig into those teaching physician guidelines from CMS, it specifically states that if we have a primary care exception, and that's what this is housed underneath, if we have a primary care exception, most commonly in like a family practice internal medicine setting, if the resident has completed at least a minimum of 6 months of training in that program, then they're able to see low or minimal complexity patients without having to be physically precepted. So let's think about that. If we have an external audit done and we are finding that, and this happens in all of the clinics that
Hmm.
I educate, what ends up happening is from a scheduling standpoint, they are racking up the schedule, putting all of those residents as if they're their own individual independent provider, and they're making it impossible for the faculty physicians to go and see every patient
Hmm.
individually. But the
Yes.
problem is internal medicine, family practice of older patients. What does that come along with? A lot of chronic
Hmm.
underlying complicated conditions. So
Yes.
again, just like we talked about in one of those other questions, we now have a situation where the clinical scenario is not matching our coding guidelines and it's creating compliance issues. So in that same way, CMS isn't saying, oh, see as many patients as you can, and you're allowed to downcode to a 3 because we will let you get paid regardless. No, they're saying you code that based on what's supported. If it's not physically precepted, you add a GE. Now, Michelle, that will result in an automatic denial, right?
Yes, it will.
No monies are going to be coming in there. But everybody has to be looking at this because just
Hmm.
because this is widely done across the country and teaching facilities does not mean that that's going to be your excuse or your scapegoat at the time of auditing.
Hmm. Yeah, I agree. It's definitely something that I have come across many times, and you kind of have to pause and have that conversation about why that's not compliant.
Mhm.
And I think that it kind of goes along with that bigger problem of undercoding and assuming you're safe when you undercode, when undercoding is just as bad as overcoding.
Mhm.
So it kind of all falls into that category. This has a little bit of a different caveat to it, but I think everybody thinks because, oh, it's a level 3, nobody's ever going to look at this level 3. That's just not true. And you have to be
Yeah.
very, very careful in these instances and making these assumptions that it's safe.
Yeah, and one more thing on that. If you think about the process that's happening now with data mining and everything that the payers are able to see without even looking at a note, you could see the volume of level threes GE coming through under one particular teaching physician, and that on its own is going to tell its own story.
Hmm.
So this isn't something where you can just, like you said, fly under the radar and get some revenue because your practice wants to pack the schedules. It doesn't work
Yeah.
that way. Compliance needs to be a large part of that discussion, and workflows have to change in order to remain compliant.
Absolutely. So on to our next question. This is also what I consider to be a hot topic.
Okay.
Currently in a widely misunderstood topic as well. So this says, I work with a weight management clinic that is prescribing weight loss drugs off the label and is using a compounded pharmacy. Are we at risk when we are billing the E&M service and other related care to the insurance companies?
Yeah, so I think at some point I need to put together and do a webinar on this because this is
Mhm.
something that every single time I see it happening in a practice, it's done incorrectly. Now, I want to say this, so that question is saying they specifically have a weight management clinic, but even if you're not in weight management, let's say you work for a large multi-specialty outpatient practice or a large hospital system, I'm seeing it happen everywhere. And
Yeah.
when it's in those larger organizations, I'm finding that when I call it out on an audit, the compliance team didn't even know that the particular practices were doing this. So
Uh-huh.
everybody needs to listen to this, even if you're a specialty provider. I've seen specialty practices doing this. Rheumatology, for example, I've seen them doing this. So we've got to make sure we're staying diligent on the compliance side, whether it's just coding and you're doing that initial review for validation, auditing, and really digging into the guidelines. So,
Mhm.
with that groundwork laid, let's talk a little bit about why this is problematic. So, one of the things that we have to remember is as a part of putting out compliant claims that are based on, the policies in place, the manuals, the guidelines, all of that, we have to remember that at the base of everything is medical necessity.
Mhm.
Now, medical necessity can be incredibly subjective, but when we have situations of different products or different drugs being used outside of FDA approval, this really starts to become an issue. And I know for myself, what I'm finding is that there are different medications like seizure medications, depression medications, and when you go to the FDA site, you can look up the current label for that drug, and it's going to show you whether or not that particular drug is approved for weight loss.
Mhm.
Now, when you take that research a step further and you start looking into payer policies, first of all, a lot of payers are starting to put permanent policies out related to weight loss drugs. And we also have situations where patients' individual plans may not cover that as a benefit, even if at a whole we know that the payer may cover it under certain circumstances.
Yeah.
So there's a lot of layers to this, but at a base level, if we know that there's not FDA approval, and another thing, maybe our listeners don't know this, but compounded medication is not FDA approved because they have no idea what's going into that and, essentially how that's being mixed up by the physician or pharmacist or whoever.
Yeah.
So when we have those two components happening, it's falling into a bucket of experimental and investigational, which then leads us down the path of self pay services.
Mhm.
So, anybody, if you're in a weight management clinic, you've got to be aware, you've got to have yourself a self pay policy. If it's something that you're uncertain of, I am doing a lot of work in this area. So, definitely reach out if you need assistance with an audit or need help formulating plans, things like that. I can definitely do that through consulting. But this is something you've got to be on top of because it's happening a lot. And, in the trends that we see from the government and other payers, we have these time periods where all of this activity is happening that we know doesn't necessarily have medical necessity, which in the near future is probably going to lead to a lot of investigations.
Mhm.
So, we're not there yet seeing it come up in investigations, but the behavior I'm seeing in the billing and the documentation practices are setting that up to happen very soon.
Yeah. And some things that I have seen that are a little concerning is when they try to hide it under something else.
Yeah.
And it's like, no, you're still telling me it's for the purpose of this, even though you're trying to attach this diagnosis to it. So, you
Yeah.
really have to do your due diligence, and it goes even further than just checking the policy of the patient that you're seeing. It's really about, is this even FDA approved
And
for.
one more thing, so that's a really good point. A lot of our physicians and practitioners think that they only have to check pharmacy coverage. So
Mm-mm.
they're going and checking the pharmacy benefit plan. They're not paying attention to anything else or checking, medical policies and things like that. And to your point, Michelle, I read a note last week that was frightening. And the provider put right in the language of their treatment plan that they directed their staff to see if the drug was approved for sleep apnea. And
Oh
if it
no.
wasn't, and it gets better. They said in the note, if it's not approved for sleep apnea, then they want it sent to the compounding pharmacy. So it was
Oh
like
no.
double face plant. It was not good. It was all written in the record. That'd be a great external audit.
Yeah, talk about a big giant arrow that says, here, 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 audit me.
Yes,
Oh no.
exactly.
Maybe they would have some mercy on them for the blatant misdirection that they have received. We have one more question here
Okay,
that I
we'll
think we
do
could
it
get
quick.
through in the couple
Yeah.
minutes. If a patient has insurance through the state where the provider is located for a telehealth visit, does that mean that the patient can be located in another state at the time of the telehealth encounter? So they give an example here. They are located in Pennsylvania, but their patients are often in Florida or Arizona for the winter months. So I'm
Okay.
assuming a telehealth encounter while that patient is in Florida or Arizona, but the provider is in Pennsylvania.
Okay. So this is going to be an issue because the patients have to be located in the state where that encounter is essentially occurring. So when we look first, and actually, let me say this. With this is something where the state law plays into this too. So we have to look at compliance, yes, for coding and billing and what we majorly focus on, but there's a legal component to this and what the states require for licensing, where that provider is personally licensed to practice medicine. And you have to make sure that that patient is located in that state where they have their licensing. Now, with that being said, one thing that some of my clients have been doing is they've been having some of their practitioners get what's called a compact license, where they can be licensed in multiple states by holding this one compact license. That's helped
Mhm.
them when, there's a lot of remote type encounters happening. The other thing, too, it's interesting they brought up Florida because I have a provider who specifically had 3 patients who go to Florida for the winter and they didn't want to lose that connection. So what they were able to do is they were able to use their original state's licensing information to complete more, I'm going to just call it more of a limited application for a license in Florida. They said it was a really quick process. It was not expensive, and they were granted a license for telehealth in the state of Florida. So, there's different options out there, but you have to research the states and be aware of what the states say individually to make sure that you have that compliance. But that scenario takes a lot of education on the patient side, so they're not doing that incorrectly.
For
All
sure.
right, so we're close on time. We're going to go ahead and end there. One last reminder, don't forget that Terry Fletcher and I are doing the telehealth webinar event next Thursday, September 18th at 10 a.m. You can go to my website, stephanieallardconsulting.com, for more information on that event and a link directly to purchase tickets. And if you're interested in joining the membership for access to questions like this with answers in a quick turnaround time, you can also find that on the homepage of my website. All right, thank you, and we'll see you all next week.
Thanks. Bye.